So today I'm going to present on the study that we conducted a few years ago. It was back in 2015, 2020. It was an implementation science study funded by NIDA, National Institute of Drug Abuse, called BRIDGE, and focused on improving HIV service delivery for people who use drugs in Kazakhstan. So why we started the study? The main problem was that people who inject drugs experience largest gaps in HIV care cascade. So if you see in green, in orange, these are total people living with HIV, and in green, people who use drugs. And you see that there are gaps all the way across the HIV care cascade, from testing to ART initiation and viral suppression. So, in Kazakhstan, we have harm reduction services, particularly syringe exchange programs, and these are the first and only access point to for people who use drugs. But unfortunately, only 50% of PUET actually visit harm reduction services, and among those who do, only half receive rapid HIV testing. The barriers are universal, they are systemic: criminalization, stigma, police harassment. But still, syringe exchange programs are very well positioned for integration of HIV services, because they are geographically well located, closer to community. They also have easy access, and they are trusted by the community. So we thought that these syringe exchange programs can be good fit for our study and a good implementation setting. So BRIDGE study was designed as a hybrid type 1 effectiveness implementation study. So our primary aim was to test effectiveness of the intervention. And these first two aims are primary aims, and the second two are secondary aims. So the first aim and the primary aim was to evaluate the effectiveness of BRIDGE intervention on linkage to HIV care for HIV-positive people who use drugs, and assess outcomes across the HIV treatment cascade, including testing, ART initiation, adherence and viral suppression. And then secondary aims, which were related to implementation, were to explore how multi-level contextual factors, such as provider capacity, stigma, organizational readiness, influence service delivery and outcomes. And then the fourth was to examine feasibility, cost, and sustainability of BRIDGE. So BRIDGE was the combination of 3 evidence-based interventions bundled into one package. The first one was social network strategy. You might be familiar with these interventions, and I think that they are by now used in all countries, including Georgia. But in 2017, when we did the study, it was new for Kazakhstan. So social network strategy is a peer-driven recruitment model where HIV negative clients are trained to recruit people from their injection and sexual networks to come and test for HIV. So the SNS strategy helped us to reach to those PUET who were not connected to the system, and test them for HIV and link to care. The second component was on-site rapid HIV testing and assisted referral. And we primarily focus on minimizing delays between HIV testing and referral to ART initiation. And the third component was ARTAS, case management model. And this, we trained the syringe exchange program staff, these were primarily nurses, to conduct up to 5 sessions of case management intervention to support HIV positive clients, to navigate the health system, to build internal motivation and stay in ARV treatment. For syringe exchange program staff, it was very new because they were not used to work with HIV positive clients. They primarily provided condoms and syringes, and some of them did HIV testing, and that's it. So they were not used to do a management of HIV positive clients. So all three components were adapted to fit these harm reduction programs, workflows, and staffing models, and they were combined, like bundled together as one package. The implementation framework we used was CIFER, and I think you already heard a lot about this framework and know very well what the means this framework consists of. It has 5 domains. The outer setting, which in our case included structural stigma, criminalization of drug use, and limited funding. The inner setting, which included organizational characteristics of syringe exchange programs, leadership, and competing interests with AIDS centers and polyclinics where the syringe programs are located. Individual characteristics, which are characteristics of period, intervention, including perceived complexity, adaptability, and strengths of evidence behind the 3 interventions, and then the process of implementation. We use this framework to build our pre-implementation phase, to conduct assessments, structured assessment, to further tailor our implementation strategies. So we have conducted a very comprehensive pre-implementation work. We conducted document review, surveys with staff of harm reduction settings, AIDS center department staff. Then we conducted focus groups with people who use drugs, with 57 actually HIV positive people who use drugs. And then we conducted consultations and community advisory board meetings with key informants. So, to better organize what we have learned, we mapped all the barriers and facilitators into CIFER framework. We learned that, of course, there is a high criminalization and police harassment toward period, limited external funding for harm reduction, and low engagement of period within the formal system of HIV care. But there is still high community demand for HIV services. There were some established peer networks and strong NGO presence. In terms of syringe exchange programs, there were some infrastructure limitations, such as spacing was not enough, privacy was not provided, there was heavy workload and competing demands and bureaucracy, and of course we had to work with the leadership. But still, most of them had supportive leadership and openness to innovation, which was regarded as facilitator for us. In terms of characteristics of individuals working there, we had low confidence in delivering ARTAS, lack of training, and a lot of stigma towards people who use drugs, even though these were syringe exchange places, but still there was a lot of stigma. But there was high motivation among peer outreach workers and commitment to client-centered care. Intervention was perceived really well, although it thought to be complex, and there were some concerns about fidelity versus flexibility. So, using this CIFER framework, we developed the implementation strategy, and we selected 4 of them. Training, first of all, comprehensive training for syringe exchange program staff, including models on SNS strategy, RTAS case management, and HIV rapid testing. And then we followed with supervisory model, which included strengths-based supervision, which was provided by the 8 center staffs to syringe program staff. And then we built community of practice in each of our clinical sites. And we provided intense technical assistance because the intervention was complex, was multi-phased, and it also included some digital tools, and that's why assistance was really critical. So this slide shows the timeline and design of the bridge study. As I already told you, that this was hybrid type 1 effectiveness implementation study. It was conducted in 3 sites. So you see CT1, CT2, and CT3. At the same time, it was a stepped wedge trial. So we started intervention at different time points consequently across 3 cities. So we started in CT1, and then after 6 months of implementation, we started CT2, and then after 6 months of implementation, we started CT3. At the same time, as you see, the data collection, which is starting from yellow, these yellow blocks, these are pre-intervention data collection, started at the same time in all 3 sites and continued throughout the study. So in data analysis phase, we compared these yellow blocks with blue blocks. Why we decided to go with this design is because we really wanted to provide intervention to all 3 sites. And at the same time, because these sites were so different, these were 3 different regions of Kazakhstan, we thought that it will give us some time to prepare for intervention rollout at each site. So, but nevertheless, this design was complicated because of the data collection. Data collection started very early in the trial, and it included 4 different forms of data collection. First was service and linkage tracking system on individual clients served by syringe exchange programs. So we collected data on each client served by the harm reduction programs. And then we collected epidemiological clinical data from the 8 centers, which allowed us to see whether these clients were referred to the 8 center and whether they received the services there and what was their outcomes. And then we also had longitudinal panel study, consisted of HIV positive participants only, and implementation data. which is focused on aims 3 and 4 and was based on CIFER framework. So as I told you, you see with this red line showed you when the pre-implementation data started to be collected. It was started in August 2016 and in all 3 sites. And this shows you that the data collection was continuous. It was grouped into past 90-day window. And there were 15 windows of data collection over the course of the project. And the data that we collected through this client tracking system was visits to syringe exchange program, how many syringes and condoms they received, how many visits to the AIDS center and purpose of their visit, and referral to other services. So,
the data that you saw, that you just mentioned, data collection, visits, and so on, part of the visit, how many syringes they took, it was all automated, right? It was from electronic record.
No, it was not, because the syringe exchange program, well, harm reduction services, they don't have automatic services, and this was live data collection, so we could not. It comes to centralized database into the AIDS center, but only since 6 months, I think, and we collected it live data through this Google-based application. So yeah, we provided nurses at the syringe exchange program with tablets, and there was a Google yes. Yeah, there was a survey that they filled in on each client, and also each client was given a QR code, so we can track and identify the same clients throughout the project and verify the identity. And they bring the QR code. It was printed on a keychain or a card every time they came to the syringe exchange site. And then for additional verification, we collected this epidemiological clinical data from the AIDS centers. AIDS centers provided us quarterly reports on these clients, on the client that came to the AIDS center. And we could link, so the data were de-identified, but still we could link the data from the syringe exchange programs to the AIDS center data by age, gender, and some randomly assigned ID, which was the same at the AIDS center and the syringe exchange site. And then implementation measures we also collected regularly. So these were the measures for implementation outcomes.
Make it the same between two different kinds of services, so the AIDS center and the community program.
So in Kazakhstan, we have this data, this ID system. Well, because in our harm reduction services, they do not collect IDs of clients, and the services are provided anonymously, but they still have to have some reporting system. So they develop their own system, like with starting with their mother's name, father's name, and then date of birth. So we use the same. And then AIDS center already know how to identify this client in the system.
It's not
No, yeah.
Based on algorithm,
Right.
which if you use constantly, will generate the same ID for the same individual.
Yeah.
Yeah. It's
Yeah.
random.
Not random. Yes, excuse me. This is, yes, not random. Exactly. So, this is the how this program was, the project was implemented. It was conducted in 3 cities of Kazakhstan: Almaty, Karaganda, and Temirtau. We regarded it as one site, and then Shymkent. At each site, we had 8 syringe exchange sites programs. And each site has 8 nurses or social workers, 16 outreach workers, and 1 supervisor from the AIDS center. So that was the team at each site. 24 SAPs, so 8 at each site. So these are the results. Overall results, we had 24,000 clients enrolled in SAPs over the course of the study. We had 14,000 clients tested for HIV. A little bit more than 1,000 were newly HIV cases. 84% were linked to care. 72% initiated RT treatment. 90% were adherent to antiretroviral treatment, and then viral suppression was reached among 55%. And here the how the bridge program increased rapid testing in syringe exchange programs. So following the bridge implementation, we saw significant improvements in rapid testing. In Almaty, it almost doubled from 45 to 115 tests per month. In Karaganda and Temirtau, also from 53 to 128 per month. And in Shymkent, it was the most significant increase from 11 to 98 tests per month, almost 9-fold increase. And we also saw case identification, HIV case identification increase. So the most high, the highest was in Almaty, from 1.5 to 2.3 cases per month. In Karaganda and Temirtau, the jump was also high, from 1.2 to 4.4 cases per month. And in Shymkent, it actually began from 0 to 1.2. And these are mean cases by months, because we collected this data through many months. And if we looked at, when we look at improvements in HIV care cascade, we saw that the awareness of HIV status increased in period. These are only bridge sites, from 55 to 64%. And then the treatment initiation increased, almost doubled, from 30 to 60%. And then the suppressed patients with suppressed viral load increased from 44 to 58%. Of course, the implementation, real-world implementation, was very complicated. We were faced with many challenges, and I grouped them by client, staff, and organizational level. So on a client level, there were structural barriers like transportation, registration, mistrust of the medical system, lack of other services like mental health, social services. So the lessons that we learned throughout the study was that we need to build trust through peer engagement, co-locate services where possible, address psychosocial needs along the HIV care cascade. The barriers on the staff level included redefinition of roles, because we had to, the project was about differentiated care, so we actually integrated new services into syringe exchange program, and staff was gradually changing their attitude to new functions. But we provided tailored training and supervision, and when they saw the results, they actually really appreciated. There was some stigma reduction even because staff started to provide new services. There were some challenges on the system level, like pressure to over-report services. We actually faced this problem in one of the sites, Shymkent, where we were provided with fake data, and we had to throw out data, and unfortunately lost like a few months of data. But then we had to provide more training to staff, and then work closely with the national partners, ensure harmonization between the training that we provided and their demands. We also remain adaptive to changing policies and standards of HIV care. We also make sure that the program was sustainable. So we included some changes into the Ministry of Health Order number 115, which govern the how the syringe exchange programs operate, including their structure, staffing, responsibilities, and performance monitoring, and integrated some of the services along the breach intervention. And then, because we saw the challenges that the staff of SAP faced in everyday work, we also included recommendations based on the challenges. And then we saw along the project implementation throughout, we saw that the great integration of SAP's harm reduction services into primary care, improved referral pathways between harm reduction and narcologists, TB doctors at primary care. We also we saw that social contracting to NGOs improved because of the integration of these breach intervention components. Actually, the SNS strategy was integrated and received social contracting funding, and some received Global Fund funding. So it remains sustainable in most of the sites. Breach was really had some catalytic influence on structural and policy change across multiple levels of the HIV health system. Well, in conclusion, I would like to emphasize that breach demonstrated that integrated HIV service in harm reduction settings is both feasible and effective. And the study resulted in significant improvements on all phases of HIV care cascade, including HIV testing, diagnosis, treatment, and viral suppression. The implementation challenges were very dynamic and context-specific, because there were variation across different sites, but also across different syringe exchange programs. We had government-run, we had NGO-run SAPs, some were based in polyclinic So there were very different variations, and we had to adapt the study all the time. So it was very dynamic. And the lesson is that implementation has to be dynamic in implementation science studies. Breach informed national policy, resulting in institutionalization of services and social contracting mechanisms for some of the breach components. And the model was scalable and transferable. It can be adapted to other programs like PrEP, overdose prevention, TB management. So it's highly adaptable and transferable. So, and in conclusion, just want to acknowledge that all of this could not be done with our primary principal investigators who were based at Columbia University and social intervention group, Drs. Nabila El-Bassel, Louisa Gilbert. The funding was provided by the National Institute of Drug Abuse. And of course, we were very grateful to our national partners, National AIDS Center, city and regional AIDS centers, SAP staff, harm reduction staff, and our participants. Thank you. If you have any questions.
Thank you, ASSEL. Yeah, just right.
Thank you, ASSEL. Which was, I don't know, unusually low, and maybe you can explain viral suppression rates for those who were on ART. It was like 55% achieving viral suppression. Yeah, kind of low. Well, so any explanation for that? And also, but this is general, not related to your methodology or whatever, but general question about the linkage to care, which is extremely challenging stage of HIV-related services. And we struggled a lot. We developed a proposal together with late Martin Iguchi, and it was randomized trial for MSM and PWID to do HIV self-testing. And ideally linkage to care, but then we were so unable to describe or to invent anything that would sound scientifically, rigorous in terms of what we are gonna do to link those people who would get tests from our vending machines, do self-testing at home, and then how can we check or facilitate that they are linked to care? We removed this as an outcome, which was okay for reviewers. The primary outcome was first-time testing using self-tests delivered from by vending machines compared to testing in any other facilities. So reviewers were okay, but probably because there is very lack of knowledge how this can be addressed, any clues or ideas would be welcome. Thank you.
Yeah. Yes, thank you. Yeah, for questions. Yes, this is true. I think the breach intervention was mostly focused on the first 90s at that time. So people who know their status and people who were tested for HIV and linked to care rather than the viral suppression. Yeah, so.
It's quite low.
Oh, you mean in the country?
Yeah.
Yes, for PWID, it's really low because they have all these social barriers. It's still, we could not remove these outer settings barriers like criminalization, stigma, discrimination. We were not able, of course, to address them with our study. And this is true that PWID have the lowest viral suppression rates among all other key populations. And then you ask for linkage to care. In this case, it was on site, everything was on site, so it was not self-testing, as you said, yeah, at home. But here in this study, it was on site, so they actually came to syringe exchange programs, and the outreach workers were there, so they physically could navigate them and link to care. And it was I mean, difficult because it took a lot of effort from outreach workers to get them into care because of the document status, yeah, legal status. Yeah, it was a lot of work.
And I would say just a general response to your question, and also based on this data, all study data becomes potential pre-implementation data for another study, right? And part of the challenge that I know that we have in Kazakhstan is that very few people who inject drugs are actually linked to opioid agonist therapies.
Yeah.
And you would see that number go up, at least from the world literature. You would likely see that number go up if, in fact, they had another system backing them up, right? I mean, so as you said, they have a lot of barriers, and they're socially isolated, and they actually don't have access in any meaningful way to opioid agonist therapies. So I think that's just, grist for another study. And in terms of your study, I think that it's such a fascinating finding, right? So we talk a lot about autonomy. The more autonomy or self-testing kinds of strategies that you can use, the more likely people are to take you up on them, right? So then the question becomes, what, if anything, is autonomous about follow-up? How can we leverage the fact that they cared enough or they were interested enough to actually take the test, right? And I don't really know the answer, but I bet you we could brainstorm some of those kinds of answers. QR codes, maybe, one of the ways of thinking about it, right? Yeah. So, I mean, it's always, those findings, I think, are so great for stage setting. Yeah.
How we saw it might be helpful to link those people who tested at homes. We described them briefly, including QR codes and some other things, but at the end we removed this outcome as a study outcome, because we are not sure that we will be able to measure it at all.
Yeah, and just to add to that is our experience from vending machines when we just tried to put there some HIV self-tests, uptake was really amazing. But within instruction, we put there some QR codes, WhatsApp numbers, Messenger, Viber, any means what was available for us, but we never got any feedback, even just like answers on the 2 questions. Have you tested an HIV? And if it was positive. Only the way they responded to these 2 questions, it was on a screen of vending machine. While they were waiting for the product vended, they just were willing to answer those 2 questions. Mm-hmm. That's the only way we got responses on those 2 questions. Yeah. So, right? Yeah, they never used any other means. Yeah.
Mm-hmm. We also had a project on HIV self-testing among MSM, and we developed the online system where they can reveal their HIV positive status, and of course not everyone, but some people contacted us and showed us the result of the test, and some of them were positive, and we used also online tools to link them to care if they needed it. Yeah.
Just maybe make one commentary and maybe another commentary, but I think really one of the interesting things that you learn from what I call these bundled interventions, and when you're going to bundle, you sort of need to think that you're probably trying to address multiple levels of a cascade. And the lesson here is, you know, you used an evidence-based, so you've got testing, and then you've got this evidence-based
SNS, it's
link.
peer outreach.
So you've got that, but then you've got the other part that you've got is you've got the RTAS, which is an evidence-based linkage. That and peer navigation are the two big ones that have got the most efficacy in there. But it's sort of the idea that when you have populations who, one, are afraid to go to healthcare systems, and when they do go to healthcare systems, they get treated badly. You can't really attack that last level of the cascade because you don't have an intervention for that. So
yeah, ARTAS was not really focusing on.
well, all the studies of RTAS actually show that it has no impact whatsoever on viral suppression. And so you got what, you know, you put into it in terms of that. So maybe thinking about that sort of next level of a, you know, a cascade. And, you know, some of the work that we're doing now is actually taking it out of the doctor's office and doing it with a video. So telemedicine, don't make them go in. So that would be, you know, maybe perhaps one of an alternative strategy versus bringing them in, you know, if you want to sort of get down the cascade. But really, you know, it's proof of concept that you do need, you know, these different strategies to tackle different parts of the cascade, you know, once you get there. And, you know, I'm not so sure you need an adaptive design for that, but it's just that you don't have the intervention that's going to get you there. And then I will comment a little bit on these sort of self-testing. So there's a number of big, you know, studies looking at the self-testing. One of the ideas is having a website, you know, where people can go. The problem that's different is that if you have a study with these self-testing and they're getting it from a website, in other words, they're ordering it, it's all staying in the virtual space, then you've got a reason for them to go back, right? In this case, it's really a bit more of a challenge because they haven't gotten there unless you provide some kind of added, you know, value. And I would say that, you know, maybe the next generation to think about that is that that goes on with the idea that, you know, they can either go on to HIV treatment or even PrEP, you know, as an alternative. So there needs to be some kind of value to going back and reporting the information, you know, whether
incentive for those who test positive and go to AIDS center. So if AIDS center was partner in this case,
yep,
if they link this new case with our client, because we had these IDs, you know,
yep,
unique, then the person would receive like sensible incentive for getting in touch with AIDS center. But study never was funded.
But
Sorry
because they're not even talking to you, you don't know whether they even one tested. But if they test negative and they have the potential to go to PrEP, you have a sort of a status neutral. And in a country where the prevalence is so low, especially among people who inject drugs, you just may not be able to get that sort of signal there. But there's some really interesting websites that they've used, and they've been testing some alternative strategies. We're doing one in Malaysia where you get a virtual assistant. So your patient navigator is virtual, and everything's done by texting. The person does not have to get seen versus standard one, hey, we'll meet with you, we'll walk you through this and stuff like that. And I just have to tell you, when the stigma is high, they don't want to see you. They just don't. You know, it's the problem is at some point those clients have got to be seen, right? They've got to get physically into these sorts of places unless you can move to it. So I think that the next generation of strategies is moving to these digital support tools and taking them out of the clinic, you know, and, you know, ministries of health are very slow, but if you could do that as part of a study to really sort of show that these virtual strategies are really quite effective. During COVID, you know, we didn't get to test them. We just did them and they did really well. And so, you know, there's no comparison group. There's no research study. It's just observation. And I will say that as a clinician, you know, essentially had almost 100% no-shows from when we moved all of our stable patients to, you know, to virtual. And because they could do their medical visit from their bathtub, you know what I mean? No childcare issues, no transportation issues, no, I'm having a really bad day and I just didn't feel like I wasn't bathing and so I didn't come in. They show up and viral suppression rates were incredible. It was really, really good. So we have to really be thinking about these strategies. And in your case, you've got this really sort of missing gap. And now what's the next question? And as Lynn said, that's your preliminary data for the next thing. So anyway, very nice job. Thank you.
Thank you.
Thank you. Thank you a lot. It's very familiar activities that we were conducting within the change program. Irma started, peer-driven intervention. This is like all this component that we had, but we were focused on recruiting new unreached drug users for our programs, also incentivize them for coming, for testing, for education, and so on. But what we did not follow up, and it was really a missed opportunity. So my question is that did you count the frequency of received services after those who were um, interacted by the programs? So frequency of HIV testing, frequency of taking sterile injecting equipment, because sometimes people come from one-fold testing, one-fold service taking. I don't count here pill HIV, but other drug users. It's very important in this percentage that is total 150%. I don't see how many times did they take the services or take testing. It's very important for us.
So yeah, this slide shows increased rapid testing in syringe programs. So how it was actually in 2017, we just started to introduce rapid testing in harm reduction settings because they used to have like blood-based testing, but then the new test appeared, so the rapid saliva-based testing, and some of the sites didn't even have this test, so we had to buy them to purchase and provide harm reduction with this test. And this shows how this rapid testing increased in this organization. And the number of visits
yes.
we have tracked, of course. I don't have data right now here, but it's also increased. Because it was low in the beginning. I showed you that less than 50% of period visit stationary harm reduction settings, because some of them are located in polyclinic and primary care. Those who were located in the NGO were better attended than those who are in primary care or run by government, run by the aid centers. So we were able to increase visits to government-run services.
And what about sustainability as the Global Fund never
yes,
research?
The SNS is picked up by the Global Fund, so they integrated it into government programs. So this is how right now they do outreach through SNS strategy.
Thank you so much. I would like to